Okay, well, I'd like to do a short presentation on cardiovascular disease in pregnancy. We tend not to think about cardiovascular disease as being a potential problem in women of childbearing age, but it is a problem. And I'm going to go over a little bit of epidemiology of cardiovascular disease and a little broader discussion on maternal morbidity and mortality. This graph shows pregnancy-related mortality in the United States between 1987 and 2010. And relatively speaking, there are several causes of pregnancy-related mortality that have trended down over this time. Those include things like hemorrhage, hypertensive disorders of pregnancy, in other words, preeclampsia, infection, embolic phenomena, and anesthetic complications. These are also known as direct causes. So that is a clear obstetric cause. Now, on the other hand, the indirect causes, things like cardiovascular conditions, cardiomyopathies, cerebrovascular accidents, and non-cardiovascular medical conditions have been trending up. These are known as indirect causes. And indirect causes refers to pre-existing diseases that are aggravated by pregnancy. Now, the big question is why? Why are these indirect causes of pregnancy-related mortality increasing? And it's not entirely clear. It may just be due to better data gathering. That's because states have changed their reporting requirements and there are changes in coding. But there are other explanations that researchers point to that are pretty credible. That includes things like older women having children. Now, as women get older, they have a higher burden of chronic disease. And there's also a phenomenon in which women who had congenital problems and would not have survived to childbearing age are receiving better treatment and living longer lives and surviving into childbearing years. And then when they get pregnant, the pregnancy can aggravate the underlying congenital disease. Other problems include increasing rates of obesity and problems with smoking. Now, cardiovascular disease is the leading cause of maternal mortality in the United States and California. It accounts for more than 33% of all pregnancy-related deaths in the United States and 25% of pregnancy-related deaths in California. One thing I did want to point out to you that you might find interesting is you'll notice that anesthetic complications have they were never that significant a cause of maternal mortality, and the risk of death due to anesthetic complications has decreased pretty dramatically over the years. In fact, maternal mortality due to anesthetic causes is estimated to be about 1 in a million live births. That's a 59% reduction from 1979 to 1990. And there are several reasons that are given for this decrease in anesthetic-related mortality. It includes things like decreased general anesthetic use. And of course, as the use of general anesthetic decreases, the risk of injury due to aspiration decreases. Also, standard practice for epidurals has diminished, or has changed over time. So test dosing is a routine practice. Incremental injections of local anesthetic into epidurals is now a standard practice. And we're using lower concentrations of bupivacaine. And in the old days, they used to use 0.5% bupivacaine, even 0.75% bupivacaine. And when you're dosing the epidural with that, you run the risk of a local overdose. And of course, bupivacaine toxicity is really a serious complication. This slide illustrates mortality by race and age. And there are a couple things that kind of stand out. The first thing that's really sticks out is the high rate of African American mortality. The rate of African American mortality is 8 times higher than whites in the state of California. And there's a belief that that's because there's increased burden of cardiovascular disease risk factors in this population, as well as impediments to care. So those are a couple reasons that are given for the high rates of mortality among non-Hispanic blacks. The other trend that you'll see here is that there's increasing mortality with advancing age. Now, it's believed that actually, by definition, advanced maternal age is any woman over 35 years old. And there's a pretty significant increase in this subset of women. So that's something that's been looked at quite a bit recently. This chart illustrates causes of death while women were pregnant or within a year of delivery. And this covers a 4-year period in the state of California between 2002 and 2006. And if you look at the top, you'll see that there were a little over 2.7 million births during this time period. And of that number, there were 864 deaths. Now, most of these deaths were unrelated to pregnancy. They included things like malignancies and accidents. But there were 257 pregnancy-related deaths. And of those 257 pregnancy-related deaths, 64 were due to cardiovascular problems. And about 2/3 of those cardiovascular problems were cardiomyopathies, and about 1/3 were other cardiovascular issues. Now, it can be dilated cardiomyopathies as well as concentric cardiomyopathies leading to death. There is a particular condition known as peripardium cardiomyopathy that accounted for, that was the leading cause of cardiomyopathy deaths in California during this time period. And I'll come back to a later discussion about peripardium cardiomyopathies. Of the 64 women who died, 60 had a live birth, and there were fetal deaths in 4 of these cases. So usually the child will survive. One thing I did want to note, if you look over other cardiovascular deaths, there are problems such as pulmonary hypertension, aortic dissection, sudden arrhythmias, valvular disease, and coronary artery disease. And I found an interesting statistic, and it said that MIs complicate 1 in 16,000 pregnancies. Now, that doesn't necessarily mean a death, but just a complication. So 1 in 16,000 women who are pregnant will have a myocardial infarction. And about 40% of those MIs are not due to atherosclerosis, but due to a spontaneous coronary artery dissection. That's a condition in which the coronary artery dissects. There's an impediment to the forward flow of blood through the artery, leading to infarction of the myocardium. So that's kind of a unique condition in pregnancy. Well, this slide is from the same study that we just looked at. It's the California Pregnancy Associated Mortality Review. It was done from 2002 to 2006. And what's of importance is to know that only a small fraction of the women who died during this time period were diagnosed as having cardiovascular disease. And that's in spite of the fact that most women who died presented with symptoms either during pregnancy or shortly after childbirth that were consistent with cardiac disease. So in other words, women presented with shortness of breath, chest pain, and fatigue. And in spite of those classic symptoms, the diagnosis of cardiovascular disease was missed in all but 2 cases. Expert review of these patient charts led to the conclusion that about 1/4 of these women could have been saved if they had been diagnosed and treated appropriately. So in other words, patients and providers aren't considering that cardiovascular disease is a risk in women of childbearing age. And that's a very important takeaway message. This is data from the United Kingdom, gathered between 2012 and 2014. And if you look at this graph, you'll see there are bars that are dark purple and lavender. So the dark bars indicate indirect cause of death. In other words, pre-existing disease superimposed on the pregnancy. And the lighter bars, the lavender color ones, show direct causes of death. These are direct obstetrical causes of death. Now, like in the United States and the United Kingdom, only a minority of the women who died of cardiac causes were known to have pre-existing cardiac problems. Only about 17% of women who died of cardiac causes were known to have pre-existing cardiac disease. About 3/4 of the women who died had additional pre-existing medical problems. Often they were overweight or obese, and often they were over 35 years old. In fact, the risk of cardiac death increased with age and was twice as high in women aged 35 to 39 and nearly four times higher in women 40 years or older. In addition, about a third of the women who died lived in communities that were socioeconomically depressed. This pie graph gives some more data from the United Kingdom. Specifically, it looks at late deaths. These are deaths that occur somewhere between 42 days postpartum and a year after birth. And you'll notice that the top three causes of death include malignancy, cardiac disease, and suicide. Next, I'd like to talk a little bit about physiologic changes in pregnancy. This slide summarizes the normal physical changes of pregnancy. Now, I've heard people refer to normal physical changes of pregnancy as nature's stress test. And this is because the mother's body is stressed as the body adapts to meet the needs of the growing fetus and placenta. Now, if there's pre-existing cardiovascular disease present, the increased stress of pregnancy may lead to subclinical disease becoming unmasked. For example, a woman who would be asymptomatic under the stress of pregnancy, especially the stress experienced during delivery and the immediate postpartum period, may become symptomatic, or in fact she may decompensate. For example, may go into heart failure during delivery or in the immediate postpartum period. Physical exam of a woman experiencing a normal, healthy pregnancy will be quite different than that same woman if she were not pregnant. As someone told me once, an abnormal finding is normal in pregnancy. And I've got some of those normal cardiovascular exam findings listed here. So you might see some things like an accentuated S1. That's due to early closure of the mitral valve. It's not uncommon to have some sort of a murmur, a systolic ejection murmur from a dilated tricuspid annulus is pretty normal. And you'll see some EKG changes. So it's not unusual to have what otherwise would be considered abnormal cardiovascular exam findings in a pregnant woman. Now, there are exam findings that should be of concern to anyone involved in the care of a pregnant woman. And that would include signs of elevated CVP or failure. So jugular vein distension, RALs, and unusually lateral displacement of the PMI. Those would be sources of concern. As I'm sure you're aware, it's normal to have increased blood volume during pregnancy, but the patient should not appear to be volume overloaded. And that's because there is vasodilation in pregnancy, and that compensates for the increased blood volume. If there's an increased aortic stenosis murmur, that's the crescendo-decrescendo holysystolic murmur over the course of pregnancy, that would be a cause of concern. Edema that's asymmetrical may be suggestive of pregnancy-induced hypertension. And then there are subjective symptoms that should cause some further evaluation. And that includes unusual shortness of breath, unusual palpitations, chest pain, wheezing, unusual fatigue, unusual tachypnea or orthopnea. This is a poster that was developed by the California Department of Health, and it's made for the general public. And you'll notice it says that the woman should watch for certain symptoms in late pregnancy and up to 5 months postpartum. And the things to be alert for are extreme swelling or weight gain, extreme fatigue, fainting, persistent cough, chest pain or fast heartbeat, and severe shortness of breath, especially when lying down. So that's pretty much the signs and symptoms we already talked about. Now, in particular, and this is important, there should be a very low threshold for further evaluation of women with these signs and symptoms if they fall into one of these categories that's listed in the pink box. If they have a history of prior heart disease, are over 40 years old, have preeclampsia, are African American, or are obese. Once a woman is suspected of having cardiovascular disease during pregnancy, she should be referred to a cardiologist for diagnosis and risk stratification. Now, as you would imagine, not all cardiovascular disease is equal, and the World Health Organization has developed a risk stratification scheme to help guide in the prognosis and treatment of women with cardiovascular disease during pregnancy. So there's a range here from Class 1, which is negligible risk for an increased mortality, and a mild risk for increased morbidity, and that ranges all the way to a Class 4 patient, someone who has extreme risk of morbidity and mortality, and then there are a couple of categories in between. What I want to do is talk a little bit about which diseases have the greatest risk, and I'll use this particular formulation to help discuss those diseases. Low-risk conditions include conditions such as mild valvular disease, successful repair of congenital heart disease, and atrial or ventricular ectopic beats that are isolated. Patients with these types of conditions should have a cardiac consultation, but they need to be seen only once or twice during their pregnancy. Class 2 diseases bring with them low to moderate risk. They should be followed up in each trimester. And some of the conditions for Class 2, or this kind of borderline Class 2-3, include some unrepaired congenital diseases, most arrhythmias, repaired tetralogy of Fallot, and that 2 to 3 condition is mild left ventricular impairment, hypertrophic cardiomyopathy, valvular disease that is kind of the mid-range, not 1 or 4, and then some connective tissue disease and aortic stenosis, and also repaired coarctation of the aorta. Diseases falling in the risk class 3 put the patient at high risk for complications. They should be seen by cardiology and obstetrics every 2 to 3 weeks during pregnancy. As you can see, this includes conditions such as mechanical valves, unrepaired heart disease, other complex congenital heart disease, aortic dilation, Fontan circulation. Fontan circulation is a condition in which there's a single ventricle, and so ventricular blood is poorly oxygenated as it leaves the aorta. So these are pretty severe conditions. Class 4 conditions are so severe that the patient is at very high risk of mortality and morbidity, and getting pregnant is inadvisable. Options include termination of the pregnancy or very frequent follow-up every couple weeks or so by cardiology and obstetrics. And the conditions in this class include pulmonary arterial hypertension, poor left ventricular function, a history of peripartum cardiomyopathy, severe mitral stenosis, severe aortic stenosis, Marfan syndrome, and native severe coarctation. So there's kind of a take-home message from what we've discussed so far, and that's that awareness is very important, and cardiovascular symptoms should not be ignored. It's especially true that cardiovascular symptoms should not be ignored in the population that's at risk for morbidity and mortality from cardiovascular disease. So that would be women with a history of cardiovascular disease, women over 35 years old, women with preeclampsia, African American women, obese women, smokers. That population is at very high risk, and we should not ignore symptoms in them. Okay, remember that patients usually aren't diagnosed with pre-existing cardiovascular disease, and it may not become manifest until fairly late in pregnancy, because it's late in pregnancy and during labor and in the early postpartum period that the greatest stress is placed on the heart. So if there's a subclinical condition, that's when you're most likely to see it. And the symptoms to be alert for include exaggerated edema or weight gain, exaggerated fatigue, syncope, a persistent cough, chest pain, tachycardia, dyspnea, and orthopnea. So as clinicians, if we're confronted with a pregnant woman with cardiovascular disease, how do we care for her? So I'm going to talk a little bit about that, and I'll also talk very briefly about some selected pathologies. Obviously, there's an enormous variety of pathologies involving the cardiovascular system, and it's way beyond this lecture. But let me talk about some selected pathologies. If a woman with heart disease is laboring, she should receive labor analgesia. That's because it reduces stress, reducing catecholamines. That helps avoid elevated systemic vascular resistance and tachycardia. And whether you're doing labor analgesia or anesthesia for C-sections, generally speaking, the preferred technique is a lumbar epidural. So a carefully titrated lumbar epidural is generally considered safe. By carefully titrated, that means it's important to avoid a sudden drop in systemic vascular resistance and blood pressure. That's especially important in stenotic lesions or cardiomyopathies. Now, a regurgitant lesion may benefit from a slight reduction in systemic vascular resistance. That's because it helps minimize the decreased SVR helps minimize the regurgitant fraction. We typically avoid subarachnoid blocks because the block tends to set up fairly rapidly. So a subarachnoid block in and of itself or as part of a combined spinal epidural technique is generally avoided. And if general anesthesia is indicated, it should be a cardiac induction. In other words, using agents such as etomidate is appropriate. So as an example, if a woman were to present with aortic stenosis, the kind of underlying pathophysiology of aortic stenosis is that there's an obstruction to the ejection of blood from the left ventricle to the aorta. There's a fixed stroke volume. So the only way to increase cardiac output is to increase heart rate, and if that occurs, there's risk of pulmonary congestion and hypotension. So these patients do not tolerate a rapid decrease in systemic vascular resistance. If systemic vascular resistance is dropped rapidly, myocardial perfusion is compromised. And that's a big problem, especially because there's typically a left ventricular hypertrophy in these patients. They cannot increase the stroke volume through increased inotropy, so they may increase rate. That'll increase oxygen demand and decrease filling time, and you can run into the problem of pulmonary edema and even cardiac arrest. Now, managing a patient with aortic stenosis who's not pregnant can be pretty challenging, but you can imagine what it's like if they have the normal changes of pregnancy superimposed on aortic stenosis. And I've got the normal changes listed here. Cardiac output increases 40 to 50% at term. It'll go up another 40% in stage 2 of labor, and can be an additional 40% in the first 4 hours post-delivery. And also in normal pregnancies, there'll be a decreased SVR and an increased heart rate. So all these normal changes of pregnancy will aggravate the aortic stenosis. And in fact, patients with severe aortic stenosis may have a valvuloplasty so they can tolerate these changes late in pregnancy. The preferred way to manage an aortic stenosis patient during labor is to administer an epidural and dose it slowly, or else do general anesthetic. And if for some reason a patient would need a vasopressor, the preferred agent is phenylephrine. Managing blood pressure in these patients can be a little bit tricky. Generally speaking, phenylephrine is a preferred agent due to the fact that it maintains the systemic vascular resistance and doesn't provoke tachycardia. Now, for regurgitant lesions, ephedrine may be preferred. That's due to the fact that they benefit from a stable or slightly increased heart rate. Keep in mind that uterotonics may alter cardiopulmonary status. So in other words, oxytocin can decrease blood pressure and increase heart rate. Ergot alkaloids such as methergin can increase blood pressure and cause coronary vasospasms. And then prostaglandins, such as hemabate, can provoke pulmonary hypertension. It's important if a patient were to have an aortic dissection that you avoid hypertension and tachycardia, but that's a pretty rare condition. Certain cardiovascular conditions require special considerations regarding antibiotic coverage, and those conditions include the presence of prosthetic valves, a history of endocarditis, or congenital heart diseases. Pregnancy is a hypercoagulable state, and patients with prosthetic valves, heart failure, or valvular disease are at increased risk for thromboembolic events, so they may be on anticoagulation throughout their pregnancy. Low molecular weight heparin is the agent of choice for these patients. It's important to balance the risks and benefits of general versus regional anesthesia in these patients, and the risk of hemorrhage versus thrombosis when managing anticoagulation. So this is a challenging patient. The best guidance for that will be found in the ASRA guidelines. This is the American Society of Regional Anesthesia, and if you consult those practice guidelines, you'll see pretty good recommendations for how to conduct the care of these patients. Typically, these patients are managed on low molecular weight heparin, as I mentioned, and that is DC'd as delivery nears, and they're continued on unfractionated heparin during the peripartum period. Okay, dysrhythmias and conduction disorders can occur during pregnancy. In fact, there's an increased incidence of tachydysrhythmia in pregnancy, especially if there's a cardiac defect like a septal defect. But generally speaking, PACs and PVCs are generally pretty well tolerated. If there's frequent ectopy, it would be important to investigate for electrolyte disorders or the presence of structural heart disease. Patients with implanted devices are managed as they are in the general surgical population. A kind of blanket statement is that cardiac drugs aren't really well studied in pregnancy. One thing that does tend to pop up in the literature is that amiodarone is believed to be associated with some damage to the fetus, and it is contraindicated if the mother is going to nurse. Just a few miscellaneous observations here. There really aren't a lot of clinical trials on care of these patients, that is, pregnant women with cardiovascular disease. So most information is based on case series and case reports. Good prenatal care and multidisciplinary team care throughout the peripartum period is really important. There's really no one discipline that has all the skills necessary to care for a patient optimally. As far as mode of delivery is concerned, there's not a clear advantage to a C-section over a vaginal delivery. But if a vaginal delivery is attempted, the patient should avoid prolonged stage 2 pushing. That would include a Valsalva maneuvers and things such as that, straining. In any case, especially as far as anesthesia is concerned, we should always avoid sudden changes in heart rate, sudden changes in preload, sudden changes in systemic vascular resistance, and maintain sinus rhythm. And if patients have septal defects, we need to be very careful to avoid any venous air emboli. Peripartum cardiomyopathy is a unique cardiovascular disease in pregnancy, and it's a serious disease. It's fatal in 15 to 50% of cases. Poor prognostic markers include patients greater than 35 years old, African American race, or multiple gestations. Kind of simply speaking, the pathology is that of a dilated cardiomyopathy. So you expect to see an ejection fraction less than 45% and left ventricular dilation. Patients with peripartum cardiomyopathy present with symptoms of failure. That includes fatigue, shortness of breath, orthopnea, palpitations, maybe even hemoptysis. They can also have signs such as jugular vein distension, and new murmurs. The diagnostic criteria for peripartum cardiomyopathy include development of heart failure 1 month before or 5 months after delivery without an identifiable cause and no prior heart disease. And then on echo, you would see a dilated cardiomyopathy. The cause of postpartum cardiomyopathy is really not known. It's suspected to be secondary to a virus or some autoimmune response. Patients with peripartum cardiomyopathy should receive an epidural early in labor to reduce stress, or also as an anesthetic for C-section. General anesthesia is also an option for C-section with a cardiac induction. And medical management is pretty similar to what you would see in most patients with a dilated cardiomyopathy. So it's important to optimize preload, reduce afterload. They may require inotropic support. Patients with this dilated cardiomyopathy may benefit from an implanted cardioverter defibrillator that reduces the incidence of sudden death. These patients should receive anticoagulation because they're at high risk for thromboembolism. And if they don't tolerate labor, which is pretty common, they may require a C-section. According to Stolting's text, that's the coexisting disease text, about 50% of patients with peripartum cardiomyopathy will see that cardiomyopathy resolve within 6 months of delivery of the baby. Now, it can persist, and if so, that's not a good thing, because it will lead to mortality in about 25 to 50% of the women who have persistent peripartum cardiomyopathy. If a pregnant woman requires cardiopulmonary resuscitation, you need to take into account the fact that she is pregnant and make appropriate adjustments. One of those adjustments is to do chest compressions higher on the sternum than usual. That's because the uterus displaces the diaphragm upward. If resuscitation is required after 20 weeks, CPR should be done with the patient in a left lateral with left uterine displacement. If resuscitation isn't successful after about 4 minutes, a perimortem C-section is indicated. Now, a perimortem C-section is a C-section performed during a maternal cardiac arrest or when maternal cardiac arrest is impending. And the purpose of the perimortem C-section is to improve the chances for successful resuscitation. Removal of the fetus and the placenta allow CPR to be more effective, and it also may increase the chances for the fetus to survive because the fetus can be resuscitated extra utero. One other thing to remember is that pregnant women will sometimes present, or will oftentimes present, with pulseless electrical activity. And when you're doing the PEA differential, remember that pregnant women are at higher risk than the general population for embolic phenomenon. They're at higher risk for amniotic fluid emboli, obviously, but they're also at higher risk than the general population for air emboli and thromboemboli. Women with preeclampsia are often on magnesium sulfate, and a magnesium sulfate overdose can lead to PEA. Pregnant women are at risk for aortic dissection, eclampsia, and acute coronary symptom, more so than the general population. So keep those facts in mind if a patient were to present with PEA. Okay, well, in closing, a few things to remember. One is awareness is critical. We can't ignore patients with signs and symptoms of cardiovascular disease. That's very true of certain subgroups. So women over 35, pregnant women over 35, Black women, patients with preeclampsia, patients with a history of cardiovascular disease, obese patients, they're all at higher risk for cardiovascular disease when pregnant. Anesthetic management needs to take into account both the presence of the fetus and the reality of the woman's pregnancy, and also the presence of cardiovascular disease. But the anesthetic management is really pretty similar in pregnant women as you would deliver to a non-pregnant woman with cardiovascular disease. So that's the end of this lecture on cardiovascular disease in pregnancy.